Hi, everyone. It's my pleasure to be presenting with Dr. Jennifer Walker today. Thank you so much for joining our session. I will start with our learning objectives. First, we will look at key consideration in pain management for older adult. Second, we will focus assessing and managing pain, especially when resident cannot self-report. Then we will review how to use regular and PRN pharmacological treatment effectively. And then we will share some helpful resources to support your practice. Next slide, please. I'd like to highlight a new Learning Hub course, which is called Palliative Essentials in Long-Term Care. The course is available through the Learning Hub, and I really encourage you to access it after today's session. The link will be shared with you with the slides. The course covers key areas including foundation of the palliative approach, care planning for both current and future needs, having goals of care conversation, and effective symptom management. It also addresses care in the final stage of life, including grief and bereavement. This is a great resource to deepen your knowledge and support your practice in long-term care. Can you go to the next slide? Now we are going to talk about the main parts of palliative approach to care in long-term care. So at a national level, palliative care includes 12 core competency areas, all of which apply in long-term care. In long-term care communities, these have been adjusted into practical, essential elements that can be integrated into everyday care. This helps teams focus on what matters the most: ongoing symptom management, communication with residents and families, knowing the person over the time, and planning ahead while responding to changes. Eventually, our goal is to make the palliative care everyone's responsibility, not just something we do at the end of life or when specialists are involved. Next, please. Optimizing comfort and symptom management is one of the key elements of a palliative approach to care. In long term, this means screening, assessing symptoms regularly, such as pain, shortness of breath, anxiety, PTSD, fatigue, and nausea. Assessment tools and documents can help ensure changes are identified early, communicated clearly across the care team, and the outcome of the assessment, along with the person's goals of care, will inform pharmacological and non-pharmacological symptom management and care plan. Of course, in long-term care, pain is the priority symptom and should be assessed routinely. Using standard tools such as PAINAD, especially for residents with cognitive impairment, is so essential. This helps guide consistent and effective care planning. And the other important part would be timely and effective pain management. This includes both pharmacological intervention and non-pharmacological intervention. Can I go to the next slide? So now I would like to pause here for a quick poll and ask you this question. When a resident in your care area has responsive behavior during the care, what are your considerations? You can select all the answers that applies. I'm gonna pause here. Do we have answer, Estelle and Fran? Shall I? There you go.
Yeah, there we go. So yeah, thanks. We'll just give maybe 2 or 3 more seconds for people to respond. Most people, 70% have responded. So it looks like on your poll, Gita, the first three answers are the most common um, interventions that people are looking at. So they're considering pain a cause, they're looking at non-pharmacological approaches and completing a thorough assessment. And about 13% say they're also administering antipsychotic before care.
Thank you so much, Fran. So this is great. Thank you so much for answering the poll. So key consideration would include completing a thorough assessment, as you all said, and using non-pharmacological approaches like redirection. It's very important to consider pain as a possible underlying cause. So we generally, as we all know, we don't want to jump to antipsychotic right away. This ties back to understanding behavior as a communication often, and there is an unmet needs behind that. Thank you for that. So we will explore this topic more later in our future slide. Okay, let's look at this case, Mr. G, together to show how unmanaged pain can cause and lead to behavior. So we have Mr. G, and Mr. G during care is showing both verbal and physical responsive behavior, including grabbing, hitting, which makes care challenging and causes safety concern. He's also guarding his abdomen, which is a strong indicator of underlying pain. This suggests that pain may be a key driver of his behavior and care refusal. Right now, there is a gap in pain management for Mr. G, and there is no scheduled analgesia, and PRN Tylenol has been ineffective. So at this point, I'd like to ask you, what would your next step be for Mr. G? You can write your answer in the chat.
Thanks, Gita. We'll give everyone just a few moments to submit any responses that they have. Okay, so that's a great first comment, doing an abdominal assessment. Yeah, great. So I think the common answers that are coming in here, Gita, is really to start by doing a thorough assessment. And people are also pointing towards the G tube as being a possible source. Yeah,
Thank
focused
you.
assessment. Yeah, bowel sounds, etc. Yeah.
Thank you so much, Fran. Thank you, everyone. Great answers. So one possible cause, as you said, could be infection. There is a concern about a possible feeding tube stoma site infection, which could be causing abdomen pain. But assessment is limited because of his pain and his guarding. So optimizing pain management is essential, not only to improve comfort, but also to reduce responsive behavior, to improve care, allow for a more thorough assessment and treatment. Thank you. I'm going to pass it on to Jennifer. Over to you, Jennifer.
Next slide, please, Esther. Thank you. Thank you, Gita. And also I want to thank Dr. Carolyn Baldwin for the use of some of the slides that I'm going to speak to today. So we're going to take a zoomed out view right now. Pain is very common in older adults. At least half of nursing home residents report pain on a daily basis, and I'm going to speak a little bit more to this point in a moment. Pain is likely underreported, underdiagnosed, and or undertreated in up to 34% of residents. And patients with dementia experience no less pain than other older adults. And in fact, they likely make up a large part of that 34% who are underreported or undertreated. When we look really closely at all the literature, systematic reviews of studies reporting pain in long-term care residents show a very large range of pain prevalence from a low of 22% to a high of 85%. But when we look closer at these studies, we see that those studies that are only relying on chart review have lower reported pain, whereas the studies that use residents' self-reported pain or proxies reports of residents' pain or use observational assessment tools show the higher rates of pain. There are two very large Canadian studies, one in Ontario and one in Western provinces in 2018 and 2019, that only ended up showing a prevalence of about 29 to 30% pain, but however, they were using only our Rafiee MDS data. To contrast that, we know that there's a study of where pain experts assessed residents with dementia in long-term care and came up with a 68% prevalence of moderate to severe chronic pain in those residents with dementia. And we know that residents in long-term care with dementia are less likely to receive opioid medications. So in 2024, there was a Canadian call to action paper published in a journal of medical site leads that highlighted the fact that daily pain assessments and documentation of pain in long-term care residents in Canadian care homes is not consistent, and pain is frequently underestimated, particularly in residents with dementia. And we know in BC, as part of the quality framework in long-term care, that worsening pain for residents in long-term care is one of the quality indicators that are monitored. So I think we can understand that residents who have moderate to severe dementia and aren't able to express their pain in the ways we normally expect are likely to have underreported pain. So we're hoping that over the rest of this talk that we will give you some tools to help with assessing and treating pain in those residents. Next slide, please. So 80% of patients have more than one type of pain, and 34% have 4 or more sources of pain. So what does that mean exactly? People can experience different types of pain depending on which tissues are diseased or damaged. The most common type of pain across long-term care residents is nociceptive somatic pain, and that is pain related to the musculoskeletal system. And so think of osteoarthritis, osteoporosis, post-fracture pain. Neuropathic pain is pain related to, let me go back. So nociceptive pain tends to present as aching, throbbing pain, and usually in those who can report their pain, it's usually well localized. Neuropathic pain is related to disease or damage to nerves or the nervous system. Think diabetic peripheral neuropathy, shingles or post-shingles pain, spinal stenosis. And neuropathic pain tends to present as an electric shock sensation, pins and needles, maybe even with some numbness or burning sensation. Now, in residents with dementia in long-term care, the most common type of pain seen is described as chronic primary pain. And that is pain where there's no underlying diagnosis or pathology determined. Now, that doesn't mean they don't have pain. And I think it's really important to remember that even if someone doesn't have a diagnosis that we can attribute their pain to, that they still have pain and we need to treat them. I've certainly heard stories of providers who don't want to treat someone's pain unless they actually have a diagnosis, and I think that is not the proper approach. I think the other reason that residents with dementia may be determined to have this kind of grab bag of chronic primary pain is that, again, they can't describe the nature of their pain or perhaps the location of it. And so they're less likely to actually have a clear diagnosis of what type of pain they have. In terms of sources of pain, as we get older, we're all going to accumulate more conditions or injuries that will lead to pain. So think of osteoarthritis or rheumatoid arthritis, where multiple joints can be affected and cause pain. We can have soft tissue injuries, spinal stenosis, as I mentioned, diabetes can lead to pain, peripheral vascular disease. So there's it's not surprising that as we get older, there are more potential causes of pain that we can have. Next slide, please. And so What are the consequences of untreated pain in the older adult? Well, they can be far-reaching and can span behavioral, psychological, functional, and even survival domains and can have cascading negative effects. So we see on this slide functional impairment, falls, slow rehab, et cetera, et cetera, et cetera. And to the last one, potential for hyperalgesia is interesting because again, if we don't recognize someone's pain and they are dealing with it for a long time, they can develop a chronic pain syndrome, which can be more challenging to manage. So in residents with cognitive impairment, untreated pain can certainly worsen agitation, aggression, depression, and can lead to increased use of inappropriate increased use of antipsychotics. And it may also increase all-cause mortality in residents with dementia, as one study showed. I think I'm going to be passing it back to Gita now.
Thank you so much, Jennifer. So this slide talks about some different kind of standard tool assessment that we use it in long-term care. The first one is OPQRSTUV framework that helps collecting both subjective and objective information, including onset, trigger, quality, location, how severe is the pain, current treatment, and residents' understanding and goals of care. For residents and people with cognitive impairment, DOS is valuable, very valuable in tracking behavioral pattern over the time. This can help identifying the links between behavior such as agitation, resistance to care, to potential underlying pain. PAINAD is specifically designed for residents unable to self-report pain. It's objective and it focuses on nonverbal cues such as facial expression, body movement, vocalization, and ensuring pain is not overlooked. It's very important to evaluate pain medication, timing and effectiveness, consider whether medication are being given proactively, such as giving the meds before care activities, and assess their impact on both pain relief and behavioral outcome. I'm going to pass it on to Jennifer again. Over to you.
Thanks, Gita. Next slide, please, Esther. Okay, so the key principles of symptom management, certainly in residents who are able to give a good history, the OPQRSTUV and physical exam are really helpful to help guide treatment. But for those who are nonverbal or are not able to articulate their pain, we're again looking, listening, and feeling, as Gita described. The PAINAD observational tool uses those skills to help determine pain. We do a thorough assessment, and we always have to consider total pain. And total pain is the idea or the understanding that we may experience physical pain, but there are other domains of suffering that may impact how we manage our pain. And so those other domains can be psychological pain, social pain, or spiritual pain. For example, a resident may have underlying dementia or anxiety that affects how they're experiencing their pain. They might have had a really bad experience previously with pain and are very anxious about this new pain that they're having. Someone may be really worried that their worsening arthritis pain is going to affect their ability to be independent and to mobilize. And someone who's perhaps facing end of life and advancing cancer, or they're very aware of that, they may be suffering from some spiritual pain, wondering about what's to come, maybe reviewing their life. And so these things can all affect how someone perceives and reacts to their physical pain. We want to address possible underlying causes, of course. We want to understand what the resident's past medical history includes. Again, is there osteoarthritis, diabetes? What other medical conditions do they have that could contribute to pain? And don't forget other basic assessments, like ensuring a resident who is restless at end of life is not restless and uncomfortable because of pain, but they're in urinary retention, and so or they've got a new pressure wound where kind of offloading the area or increasing the repositioning is going to help them. Again, with the case of Mr. G, he was showing signs of abdominal discomfort, and there were lots of good responses as to how we would assess that and what could possibly be causing his pain. It's always important for us to be considering a patient's goals of care so that any treatment that we're going to offer will align with those goals of care, with the resident's values. And again, we might need to have a new goals of care conversation with the resident or with the substitute decision maker. We're going to talk a little bit more about pharmacologic treatments in the next few slides, but it's always important to remember non-pharmacological interventions that can be used. So we can heat and cold application, repositioning, massage, gentle exercise, and then don't forget those other supports we can use for total pain. We can get spiritual care involved. We can perhaps have music therapy to help reduce anxiety and help distract briefly anyway. Okay, over to you, Gita.
Thank you, Jennifer. So can I go to the next slide? Thank you so much. So let's review Mr. N's situation now. So Mr. N lives in our care community and has Parkinson's disease and dementia. And these two diseases has huge impact on his movement and cognition. He also has communication challenges, including hearing loss, language difficulties, which can limit his ability to express his need. In addition, he has multiple chronic conditions such as diabetes, COPD, hypertension. It's also very important to note that Mr. N values autonomy and independence. So our care approach should aim to support choice, dignity, participation in his care as much as possible. Can I go to next slide? So overall, clinically, Mr. N presents with severe cognitive impairment, with disorientation to time and place, inability to follow direction. His communication is significantly limited, resulting in difficulty expressing pain, fear, or discomfort verbally. He experiences shortness of breath, anxiety, restlessness, PTSD during care, particularly during period of the overstimulation. Mr. N occasionally reports bilateral hip pain, experiences impaired mobility related to Parkinson's disease, and has disrupted sleep and reports of distressing dreams. He also has sensory sensitivities, including intolerance to bright light and television. This is our Mr. N. Can I go to the next slide, please? So the key challenges, let's look at the key challenges for Mr. N. So first, having both Parkinson's disease and dementia makes care more complex. Second, resident has difficulty talking, communicating. So this means he may not be able to be clearly express his needs, including pain, and staff need to understand his behavior. Third, pain and other physical symptoms may not be recognized and may instead show up as behavior, such as agitation or aggression. Poor sleep is also a concern and can lead to increased daytime agitation, fatigue, reduced ability to cope. There is a higher risk of injury to both resident and staff due to behavior and mobility issues. Can I go to next slide? In this case, effective symptom management follows a holistic and multidisciplinary approach. Pain is regularly assessed using observational tools, and medications are adjusted based on behavior response. We provide non-pharmacological strategies such as environmental adjustment, reassurance, and consistent routines. Parkinson's symptoms are also managed through timely medication administration We also address sleep using good sleep hygiene strategies to reduce nighttime disruption. Anxiety is managed through calm communication and reduction of stimulation. Other physical issues such as constipation are proactively treated as they can contribute to discomfort and behavior. So overall, as a whole, effective symptom management can significantly reduce behavior distress, improve safety, and enhance quality of life. Over to you, Jennifer.
Thank you. So, as I think I mentioned, for those residents who can express their pain and can answer an OPQRST-UV framework and give a numeric pain score, it's easier for providers to determine what type of pain they have, whether they have intermittent pain and only need PRN medications, or whether they should be on a regular scheduled dose because their pain is more constant, and also determine what kind of non-pharmacological interventions could also be used. But in those residents who can't express the pain, and yet we are seeing behaviors that are suggesting pain, we can give an empiric trial of analgesics. So what does that look like? Again, so as in a patient with Mr. N, we see he has behaviors that are suggestive of possible pain. We can give a trial of regular analgesics. We monitor over time. If his behaviors decrease, then we can assume that he likely is having pain, and we can carry on with that regimen while continuing to monitor. So again, in someone like Mr. N, we know that he has bilateral hip osteoarthritis. He also has diabetes, so maybe he has some peripheral neuropathy. Before starting a trial of medications, we'd probably want to discuss this with his substitute decision maker and just provide the rationale. You know, the staff are seeing these behaviors, which we believe are related to some pain. We'd like to try some regular analgesic medications to see if it improves his behavior. And so I would always consider starting with something very mild, like acetaminophen. And then we would monitor him over time. Of course, we would also be using appropriate non-pharmacological approaches. If his behavior improves over time, then again, we can continue with the regimen while monitoring. And I would suggest that these should be regular scheduled medications, not just PRN medications. And then if his behavior is not improving, then we could consider a trial of a stronger agent, such as a low-dose opioid, or even an agent for neuropathic pain. As we know, Mr. N has diabetes, he may have diabetic neuropathy. We could consider something like a regular trial of pregabalin. But again, we would be discussing these changes with the substitute decision maker prior to instating them. Next slide, please, Esther. And so this is a study that looks at this exact thing of an empiric trial of analgesics. And there were several studies that have been done that have shown reduction in agitation, reduction in overall neuropsychiatric symptoms, and reduction in pain in those residents. So again, what they did is they had about 350 residents. Half of them were randomized to just get usual care, the other half to a stepwise approach to analgesia, getting first regular scheduled acetaminophen up to 3 grams a day. And then if symptoms weren't, their behavioral symptoms weren't improving, they would be stepped up to a low dose morphine up to a total of 20 milligrams a day. And then if again not improving, then something like pregabalin would be started or added on to see if that made a difference. And then after 8 weeks, the two groups were they were allowed to have a washout of any medications, and then it was started again. And it did again show significant improvement in behavior and pain. Next slide, please. And so this is just more of a visual approach to this empiric treatment. And this is an adaptation of the WHO pain ladder that many of you are probably familiar with. And this was developed by Dr. Romaine Gallagher to be used in people with dementia. And so again, you see, as in the WHO pain ladder, we start on the left with a mild analgesic, acetaminophen. We're going to dose it regularly. We're going to be monitoring behavior. If the behavior is persisting or increasing, we're going to step up to an opioid. And this slide doesn't include morphine, but of course, in most care homes and certainly where I work, we're using hydromorphone, morphine, less likely oxycodone. And we're always going to make sure we include a laxative because we don't want to be causing more behavioral issues because of constipation in the resident. And again, we're going to continue to monitor. And then if the behavioral symptoms are persisting or increasing, we'll probably increase the opioid dose and maybe consider something stronger, or even ask for a pain specialist consult. We might consider something stronger like methadone or fentanyl. With any of these steps, we're going to be using, of course, behavioral and environmental interventions as appropriate. We may add on adjuvant NSAID medications. So for example, pregabalin, I've spoken about it a couple times. It can be useful in neuropathic pain, and we're going to continue to monitor distressing behavior. If the resident's behavior isn't improving, we can also consider reducing the neuroleptics that may have been put in place to manage the behavior before. And I think I'm handing over to Gita again right now.
Thank you, Jennifer. So this slide talks about effective PRN dosing. So a key principle in pain management is that persistent pain should not be managed with PRN alone. Instead, it requires both regular and around-the-clock medication to maintain consistent comfort. PRN meds only are used or best used for breakthrough pain, such as unexpected flares, or incident pain, such as during movement, wound care, or procedure. So I'm going to pause here and I'm going to do a quick check-in with you. I'm going to ask you a question. How confident do you feel giving opioid, especially giving PRN opioids? Please go ahead, reflect, and rate your confidence from 0 being not confident and 10, which is very confident, and enter your answer in the chat for us. And Fran can monitor the chat. Thank you, Fran.
Yes, we'll do. Looks like high numbers so far between 7 to 10. So in this group, it does seem like we have, yeah, a significant amount of confidence providing effective PRN dosing. And so one of the great things about that is that I think when we're working in long-term care and there's new staff and the staff turnover, at least in my experience, there was just always room for more education and to, share what we know about giving PRNs with newer staff who may not be as comfortable. And yeah, sometimes there still is just this fear around giving PRNs and yeah, just reminding staff, what Jennifer, Dr. Walker was mentioning earlier about the risks of not giving pain meds, that there really are real risks when we don't treat pain, that people can be, spending more time in bed, having worsening behaviors, etc. Their intake, their sleep, so many things are affected by pain. And so when we can kind of zoom out for the other staff that we're working with and share this knowledge that we have about how to effectively give PRNs, when we're seeing more than 3 given in 24 hours, to really look at, okay, is this pain properly managed? Should we start a regular? Should we be increasing doses? All of that knowledge, is really important to share with our colleagues to support the residents. Yeah. Thanks, Gita.
Thank you, Fran. I'm going to pass it on to Jennifer.
Next slide, please. Thank you. Thanks, Gita. And yes, thanks, Fran. So I just want to talk a little bit about effective opioid administration because, again, as Fran mentioned, it can be a little bit anxiety producing for staff, new staff in particular. And so providers, you're often going to see them ordering PRN sub-Q meds opioids, Q 30 minutes PRN or oral PRN meds Q 60 minutes or Q 1 hour. And the rationale behind that is related to how quickly different administrations are going to achieve the maximum plasma concentration. So on the left-hand side, you see that with IV administration of opioids, it's very rapid. Within 6 minutes, we've achieved peak concentration, and the pain, they're going to get very rapid pain benefit, but then they're going to have a quick drop off. For sub-Q meds, it takes about 30 minutes for the plasma opioid concentration to reach its max and for resident to get benefit. And then we're going to see a drop off to at about 4 hours. It's going to start to become less effective. And then for oral opioids, it takes 45 to 60 minutes before the plasma concentration level gets to max, where the patient should be getting the benefit from it. So that's just to say, if a resident has had a sub-Q opioid dose, either a scheduled dose or a PRN, 30 minutes or more prior, and they are still in pain and asking for more pain meds, it's absolutely appropriate to give them another dose. They're not going to be getting more benefit from that previous dose, and they do need another one. Similarly, if someone has received an oral opioid an hour before, either again a scheduled or a PRN dose, and they're asking for pain or looking like they're in considerable pain after an hour, it's absolutely fine to give them that PRN breakthrough dose. And on the right, you see just kind of a schematic of patient getting kind of some scheduled dosing and then having extra pain around the time of their scheduled dose. It's absolutely okay for them to get a breakthrough dose at that time. You'll see that their pain is going to improve. And if they're asking for more, then they should get it. And so as a provider, what I'm looking for, again, is how many breakthroughs is a resident needing to be comfortable. And that allows me to consider whether I need to adjust the dose, or if they haven't been on a regular scheduled dose already, it allows me to consider starting one if appropriate. And so if residents are not being given breakthroughs when they need it, then I don't recognize that they need a change in their dose. So it's really important to be administering if they're having pain. And that's kind of the rationale behind it. Next slide, please. And so just monitoring for side effects, because certainly, again, this causes a lot of anxiety and worry, and not just in long-term care staff. Certainly, I see it in acute care as well. And the biggest concern, of course, around opioid administration is the risk of respiratory depression. However, if we monitor for sedation, we can feel pretty confident about giving a regular breakthrough opioid at the prescribed interval if needed. So people are usually going to become sedated from opioids before they experience any kind of respiratory depression. Less opioid is needed to produce sedation than it is to depress the respiratory rate. So sedation is a particularly sensitive indicator of impending respiratory failure. So this is a scale that's used by anesthetists, and I think post-operatively and so on. And it's just, I'm just using it as an example for you to recognize that if a resident is awake and alert and having pain, it's absolutely fine for them to get more pain medication or a breakthrough if they need it. If they're slightly drowsy, but they can be roused, again, it's acceptable for them to get it. If they're becoming more drowsy on an ongoing basis and kind of nodding off or drifting off during conversations or during meals, that is considered likely too much opioid. And so probably we'd be monitoring the respiratory rate, considering a reduction in dose, and definitely calling the provider to say, hey, I think this resident's on too much opioids. I think we need to adjust it. Maybe we need to consider another medication. And obviously, if they're deeply somnolent and with minimal or no response, then and they're not dying, let's make sure we have that caveat. So obviously, patients right at end of life are going to be non-responsive. We don't want to be holding opioids then. But if they've been otherwise really well and had a recent kind of change in their opioid dose and they're now somnolent and not responsive, then certainly that's unacceptable. We don't give any more opioids. Call the provider right away. And be monitoring the respiratory status. We really don't like to give naloxone unless absolutely necessary, but and usually just monitoring respiratory status and not giving any more opioids and making sure provider knows is going to be adequate. I think that's it. I'll pass it over to you, Gita.
Thank you so much, Jennifer. Can I go to next slide? Yes, thank you. This is the S-bar that we are using in Fraser Health Long-Term Care for a few years. It has a great outcome so far. This S-bar is a good tool for assessing pain and communication with our physician about the pattern and recommendation. If you are interested, there will be a copy to reference in the slide deck, and it will be sent out after this presentation. I think this is the end of our presentation. Esther, over to you.
All right. Thank you once again, Jennifer, Jada, and Fran, for such an informative presentation. I don't know if we have people with questions. Now we can entertain questions just before we wrap up the session. You can use you're welcome to make your comments or to ask your questions, or you can also leave it in the chat.
So far, it doesn't look like there's any questions, Esther, but we can hang on for a few more minutes because we're ending a bit early. If anybody wants to stay on, you're welcome to unmute or put a question in the chat, and we'll stay here for a few more minutes if you have any other points. Oh, it looks like Monica. Yeah, go ahead, Monica.
Sorry, took me a moment to get to the unmute. I was curious about the opioids and reaching plateaus, like when we're talking about either IV or sub-Q. Is there a typical amount of time or frequency of doses where somebody is going to hit that plateau and not have any further benefit by having an additional dose provided more frequently? Now it's dependent on the individual and other medications, perhaps.
Yeah, it really depends on the cause of the pain. I think usually we are looking to see how many breakthroughs are needed, and if in a pain crisis, someone may be getting a breakthrough every 30 minutes until their pain is settled, and then we kind of reassess what the scheduled dose should be. Certainly, some people do better with one opioid versus another one, so we may change. Again, if other agents like neuropathic agents, again, may be more beneficial in certain types of pain than opioids necessarily. We might just be getting more side effects by increasing opioids, whereas we could consider switching to something else. So if a patient is still saying they have pain, we are asking staff to give them another breakthrough dose at the time, or at the scheduled time. And then if it really doesn't seem to be working, the provider needs to reassess and kind of determine what's going on, I think.
Thanks so much.
Gita, do you have anything else to add?
No, well said. Thank you so much. Great question, Monica.
Yeah, great question, Monica. We have a couple questions in the chat. So one question, how heavily do we weigh fall risk when starting empiric opioids for behaviors?
I can start, Jennifer, if I may. I would go back to residents' course of care and see, how much risk they would like to take, quality of life. Do they want to live at risk because they want to have the better quality of life, and walking, or I don't know if the resident's walking or not. But it depends on residents' goals of care, I would say, and a substitute decision maker, conversation, families conversation, and looking at the person as a whole. Hey, so I don't think it's a black and white answer. So it depends on many factors, particularly goals of care. So Jennifer and Fran, over to you.
Yeah, and so, interestingly enough, one of the earlier slides that talked about the consequences of untreated pain, one of the consequences is increasing falls, right? So it is a little bit of a balance, right? And I think another study that I had a look at, like, so the one empiric analgesic that did improve function was acetaminophen. So like scheduled acetaminophen actually was the one shown to improve function as well as pain and reduced behaviors and so on. So, maximizing acetaminophen is always I think it's a really useful thing to start with before considering opioids, and then maybe like really tiny doses. And so just my experience, that there are elixirs, hydromorphone and morphine elixirs that allow us to titrate down to really tiny doses, right? 1 milligram of morphine is really a small dose, or 0.1, 0.25 of hydromorphone. So the liquid formulation allows us to go with really, really tiny doses and start really low and see how we do. But again, I love adding it on to acetaminophen already because I think it helps to reduce the amount of opioid that we might need.
Thanks, Jennifer. I think to add to that, in terms of your small doses, I could say we also saw great results for some residents using very low dose methadone. So 0.5 milligrams, 1 milligram, Q12 for post-stroke pain when we wanted to, because methadone can be so helpful with neuropathic pain, and it's great that we can use such low doses, and of course doing the appropriate assessments before with ECGs, etc. But if it's appropriate in terms of goals of care, that can be another very useful tool for dosing in long-term care. So we have a couple more questions and still have 7 minutes left. So Jennifer, I don't know if you want to tackle this one. Is ASA useful in pain management, especially for PVD?
Yeah, I'm not sure if I have a lot of experience in that. I mean, NSAIDs can be really useful. However, the risks of NSAIDs in elderly are well documented, right? The risk of renal failure and bleeding and so on. So I think I would tend to shy away from those initially, and then I guess if you weren't able to achieve good pain control with other methods, I guess having that discussion about whether it's worth trying something like that, given the potential risk for, the renal impairment and bleeding. I think that would be my best answer.
Great. Gita, did you have anything to add for that one?
No, thank you so
Okay.
much. Great
Okay.
question.
So the next question is, what is the role of cannabinoids in pain management?
There's a lot of excitement, right? When we've had medical marijuana and available and so on, but I haven't found that it's hugely, hugely beneficial. I think it's considered like third line or something, perhaps for neuropathic pain. I don't use it. That doesn't mean that I don't have patients or, who say, I use it, I want to use it, totally fine, or they want to try it on their own, and I think that's fine as long as we're monitoring for any other potential risks. But I don't necessarily find it that it's one I would go to beyond anything else. I mean, it sometimes can have appetite stimulation and anti-nausea effects in certain conditions, but not something I use very often. But if people want to try it, I'm open to it.
Thank you. I will just let everyone know in terms of the PowerPoint and the recording and other links for the tool that Gita showed, that will get emailed out. It's usually in about a week after the presentation. So you will get that. And the last question we have here is, what's the nurse responsibility on residents with pain who refuse to have pain management due to their belief system? And it sounds like in this case, care aides are not comfortable providing care, giving showers, etc. Sounds like it's very distressing.
I can start answering this question. Yes, this is very complex situation. So as a nurse, I would keep offering, medication, keep monitoring pain, skin, safety, keep documenting about, what I am seeing, what I am offering, keep talking to residents, keep talking to SDM families. And resident, if they have cognition, it is within their course of care, they have option. So if they are refusing, it's hard to see, that their pain are not managed. But I guess I do my nursing responsibility as usual and keep offering, keep approaching. Other than that, I have no other idea what we can do. Fran and Jennifer, what do you think?
Yeah, I think when we approach these situations, I always just try to come with curiosity and yeah, speaking more to the resident, or in some cases it's the family who feels really strongly that the person shouldn't have, or the SDM feels strongly that they don't want pain meds to be used. And I just try to be curious about what's behind that. Can you tell me more about that? Can you tell me what pain medication means to you? Because in some cases it is something that we can help guide and support. Sometimes it's a spiritual, as in this case, a belief system. Some people feel that that their suffering is part of life and that they need to suffer, and feeling pain is something that they actually want to feel. And in that case, perhaps connecting them with spiritual health to kind of talk through some of those beliefs in terms of their spiritual understanding of pain could be helpful. Other times it is, just knowledge gaps in terms of what might happen when someone's on pain meds. And if we can just be curious and ask a little bit more about, what's your understanding of pain medication and what we would use and what the outcomes might be. Sometimes it's just very kind of basic information that we can offer and share. And yeah. Oh, sorry there. And so I just try to really be open and curious, and as Gita said, just reapproach people, and also support the staff that, it's really hard to make people watch people make certain decisions sometimes. And of course, we want to keep staff safety in mind and have good care plans and try to optimize things the best that we can. And Monica, did you want to add something?
Yeah, thank you so much, Fran. And I love the idea of kind of exploring what the person is up to. What is it about the medication that makes them uncomfortable and not wanting to use it, to see if there's any opportunities there for us to provide some alternatives or education. And I also just wanted to note that, if your team does have a social worker, and I understand I'm a social worker, I think OTs can also do this, but also about, are there other ways we can approach the pain management? Has this person ever engaged with mindfulness activities? Is there ways that they could attempt to reduce some of the discomfort they're experiencing without a pharmacological alternative? And I appreciate that probably Roxana's message is perhaps beyond a mindfulness exercise, but just to keep that in mind, that there may be other opportunities with your other team members to maybe bring it back to them and see if there's something else to consider.
Thanks, Monica. I can see that we're at time now, but I think we're leaving on a great point that good, effective symptom management in long-term care and with residents really is a team approach. We want to involve the resident, their family, the allied health team, especially in these complex cases. It's so valuable to come together and discuss things. So thank you so much to Gita, to Dr. Walker, Esther, the BC Centre for Palliative Care. And yeah, stay tuned in your email and please check out the course on Learning Hub. Thank you so much.